Thank you for listening to the National Award-winning PRS Journal Club podcast. I'm happy to present your hosts, Drs. Lily Mundy, Raj Parikh, and Kyle Sanniec.
Hi everyone, and welcome to the December 2019 edition of PRS Journal Club podcast. I am Lily Mundy, PRS Resident Ambassador from Duke University, and I am joined by my co-resident ambassadors, Raj Parikh from Washington University in St. Louis and Kyle Sanniec from UT Southwest. Today we have the honor of being joined by Dr. David Song, Chair of the Department of Plastic Surgery at Georgetown University Medical Center. Thank you so much, Dr. Song, for joining us for this PRS Journal Club podcast.
Thanks for having me. This is a lot of fun.
The articles that we will discuss can be read for free on prsjournalclub.com, including an archive of all past Journal Club articles. The next article we will be discussing is a systematic review of the impact of acellular dermal matrix on aesthetics and patient satisfaction in tissue expander-to-implant breast reconstruction from a multi-institutional group of authors at UCLA and University of Michigan, led by senior author Dr. Paul Sederna. The authors in the study set out to evaluate the aesthetic impact of ADM and implant-based breast reconstruction. To explore this question, they performed a systematic review of the literature to evaluate aesthetic outcomes for tissue expander to implant-based breast reconstruction with ADM versus total submuscular implant coverage. The authors excluded direct-to-implant and prepectoral implant placement in their study. They identified 9 manuscripts meeting their inclusion criteria. All were retrospective reviews published between 2011 and 2018. 7 of the articles described using ADM as an inferior sling with pectoralis muscle release, and 2 didn't specify the technique for ADM use. 3 of the 9 articles evaluated patient-reported outcomes, 2 using the breast Q and 1 with a non-breast Q scale. All 3 of these articles found no significant differences in tissue expander to implant patients between total submuscular and ADM coverage. The other 6 articles looked at aesthetic outcomes as measured by an external observer. 5 of these 6 used a panel of evaluators scoring blinded photographs, with the final paper evaluating 3D photography and anatomical measurements. 5 out of 6 of these studies found significant improvements in the aesthetic results in the ADM group. The most commonly identified factors that contributed to the improved outcome in these studies were the appearance of the IMF and the inferior breast contour. The difference in satisfaction between the patient-reported outcome studies, which found no difference, and the external observer-evaluated studies, which did find a positive difference with ADM, the authors hypothesized was related to the ability to make a direct comparison between ADM and no ADM for the external comparison group, whereas patients will only experience one option, i.e. patients will only experience what they went through, and they don't have the ability maybe to see the subtle differences between the 2 options. So overall, I thought this was a nice review that discusses some of the value of using ADM in implant-based breast reconstruction. As is the case for all reviews and meta-analyses, the results they present are only as insightful as the studies that they reviewed. The authors did not focus on a difference in complication rates, although they did note there was no difference in revision rates for the aesthetic concerns for the papers they reviewed. The review also doesn't capture, some of the other potential advantages of using ADM, such as the number of tissue expander fills, the time to expansion, or the amount of fluid that's able to be placed in the operating room. And then lastly, it almost in some ways feels a little bit outdated, just given how quickly ADM has become so ubiquitous in implant-based breast reconstruction, with total submuscular coverage of tissue expanders and implants becoming increasingly rare, as well as the current popularity of prepectoral implant-based reconstruction, which they didn't evaluate in the study. So with that, I'll turn it over to you, Dr. Sung. We're curious to your thoughts on the review and how either some of the papers that they discussed or their summary of results might change anything in your practice.
This was a really interesting article looking at, unfortunately there's not a whole lot of articles, so they're just pulling from less than a dozen articles, right, that they can actually vet that met their criteria, even though they studied over 880 studies that was part of this review. It's interesting to note that the objective reviewers saw an aesthetic difference. I think that's what we're looking for, but the patients didn't really see that difference. And I think that if you dive a little bit deeper, and it's been my experience that the game changer in ADM is not necessarily the aesthetic ultimate outcome, but it's the process and it's the pain factor. Anytime you do a submuscular placement, you're going to have more pain, and I think people have proven that. And so that has to be balanced with the potentially higher complication rate with ADM and infections and seromas and so forth. So I would love to have seen not just an aesthetic aspect of it. I know that's beyond the scope of what they tried to set forth, but really diving into the overall aspect of comparing apples to apples and looking at, when they mention patient-reported outcomes, they should also look at pain and also completion, time to completion. I wrote a paper a long time ago looking at, there's just less fills, especially because of ADM used, and you can actually expand faster. And so that's another component of this as well, the financial aspect or the financial health and outcome of these patient populations. Again, outside of the scope of this article, but important in my opinion that has to come into the discussion in a forum like this where we're discussing the merits, the aesthetic merits of an ADM versus non-ADM patient cohort. So overall, I thought this was well done. The methodology was solid. It would have been nice, again, to see more papers, but again, that's sort of the nature of our journals and our manuscripts. The vast majority are going to be retrospective, and the vast majority are going to be reliant upon outside reviewers for aesthetic outcome, which some patients may have the same outcome, yet have a difference in perception by different experts. So those are some of the limitations of an article like this.
Yeah, I completely agree. And I think one of the limitations in their scope, as you kind of had mentioned, was only looking at tissue expander to implant that stage, whereas a lot of the values, I think, at least clinically that we see are likely at the initial tissue expander placement in terms of pain and ability to fill, and then time to that surgery. How much at Georgetown do you still have surgeons that are performing submuscular tissue expander implant coverage?
Yeah, it's interesting. So I've been here almost 3 years, and I have not seen one submuscular placement of a device, whether it's an expander or an implant, in 3 years I've been here. I think that clearly at Georgetown it's almost an obsolete operation. Our routine operation is a direct-to-implant prepectoral placement, and that's something that we do. 95% of all our prosthetic-based reconstructions are done that way. It's the rare patient that gets an expander, and if they do get an expander, it's going to be in the prepectoral position as well. And so I have not seen a subpectoral placement of a device in over 3 years. It's a fascinating shift in our paradigm. I think most centers that are high volume reconstructive centers are seeing similar things. This, of course, begs the question as to our breast surgeon colleagues, right? Because much of this is predicated on their skill set and the communication between us and them. And so that's typically, in my opinion, a proxy for how well the breast team and the plastic surgery team are communicating when you see a lot more prepectoral reconstructions, especially direct implant.
And we've talked about this in our podcast previously when, sort of comparing prepectoral and subpec placement. But, I don't think in residency I've actually personally ever been involved in a case that wasn't a total submuscular implant coverage. Raj, what has been your experience at WashU? Is this something that's sort of fallen to the wayside for you guys as well?
Yeah, definitely. I would completely agree with what Dr. Sanniec said. In the time I've been a resident, there's definitely been a huge shift first towards ADM-based reconstruction, and then subsequently over the last 2 or 3 years towards DTI, pre-pec reconstruction. And I would say that probably now closer to 80% or more of our reconstructions are direct to implant, pre-pec reconstruction with ADM. There is still one surgeon at our broader institution who does total submuscular coverage. So I have seen that, but I would say overwhelming majority of people at our institution and the affiliated institutions are doing ADM-based reconstruction, and out of that, a majority of it is now direct to implant. And I think that's just been the trend, as Dr. Sanniec mentioned, nationally. So I think you will see that continue to happen.
One of the reasons why I selected this article, and I thought it would be sort of timely for us to discuss now, even though sort of the two outcomes that they're comparing, one of them isn't really in widespread use anymore, is just the use of ADM and how we're talking to our breast reconstructions about this, especially in light of everything that's been coming out through the FDA and through implant safety and use of alloderm. Has this come up in your practice with your patients, Dr. Song, and how are you having a preoperative discussion with patients about the utility or the need to use alloderm in their breast reconstruction?
Many patients have started to question what an alloderm or an ADM is, and we spend some time talking about it. We have literature that we send home with patients. To me, I still don't know of a way to do an effective prepectoral direct-to-implant reconstruction without some sort of matrix, whether it's dermal matrix, whether it's something that's prosthetic, because it's hard to control that pocket, especially when someone has a larger pocket and wants to be slightly smaller. So I think that that's a critical discussion that you have to have. We go through the risks and potential complications. There's some authors and some manuscripts that talk about the fact that there's a higher rate of seromas and complications with ADM-based reconstruction. So I think it's incumbent upon us to discuss the full spectrum of options, not just prosthetic, but autologous, but at the same time when we're dealing with prosthetic reconstruction, I think it behooves us to mention the risks of ADM and what they are and the incremental additive potential risks thereof.
Kyle, what have been your experiences at UT Southwest, either with implant placement, use of ADM, talking to patients about ADM?
Yeah, so a majority of patients at UT are getting implant-based reconstruction with alloderm. We are kind of a mix, probably now getting more pre-pec, but we still do a fair number of submuscular with some alloderm slings. At Parkland, we've kind of transitioned, we've kind of run the full gamut. When we started, we did a fair amount of submuscular coverage, then transitioned to more alloderm and then pre-pec. And then kind of transitioning back with kind of the news, the FDA kind of came out saying it's not exactly, they've never fully approved it for use. And so they actually transitioned back at Parkland to doing more total submuscular coverage, for a couple of reasons. One of which was, the FDA kind of thing, they weren't really sure. And also we had some issues with patients getting onto their cancer treatment given the socioeconomic status if they developed wounds and issues like that. So we kind of had the full gamut. I am interested though in what the FDA's discussion is going to do to payers who, are the insurance companies still going to cover alloderm for breast reconstruction specifically? And I don't know the answer to that. I was wondering what Dr. Song was thinking about that.
Yeah, it's a tricky one, right? Technically the FDA usage of ADM in the breast position is not definitive and definitively approved rather. And so I'm not sure where this is going to turn out. I think that the horse has already left the barn, right? I mean, I can't remember the exact statistic, but the vast majority of plastic surgeons now across the country that do prosthetic reconstruction are using some sort of matrix, and most of those matrices are acellular dermis in nature. Pick your company. So I think that we have the long-term data, the safety and efficacy of it, and clearly with this article showing, aesthetic, at the very minimum, aesthetic equivalency, but many of our colleagues showing aesthetic superiority with ADM, particularly in the lower pole and the IMF definition. So that's going to be a tough one to claw back, I think, for any regulatory body because of the incredible inertia that's already been in place for the last 10 years. I mean, I think I put my first piece of ADM in 2002. And so it sounds like, ancient history now. But, since that period of time when we first started ADM use, and that was the classic subpectoral device placement spanning ADM. And now we've come to a brand new era of direct-to-implant prepectoral position. And again, I don't know how I would be able to do that without some sort of matrix.
I think with that, we'll end the discussion of this article. Thank you everyone for a great discussion. If you like this podcast, please feel free to share with your colleagues and friends and rate us on the Apple iTunes store. Also remember to tune into the other 2 articles that we will be discussing on this month's podcast. Finally, please join us for our monthly journal club on Facebook, where we will be able to interact directly in real time with this month's selected articles' authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not done so already. It is there where our monthly journal club takes place. And once again, thank you so much, Dr. Song, for joining us.
Thank you so much.
Thank you for listening to the award-winning PRS Journal Club podcast. Be sure to read all of the articles being discussed, including some of the classic pairings from the archives, for free on prsjournal.com.